Hello and welcome to this video discussion in conjunction with Radcliffe Cardiology and Cardiac Failure Review Journal. I'm Aniket Rali, a fellow in advanced heart failure at Vanderbilt University and one of the members of the editorial board for Cardiac Failure Review. It's my distinct pleasure to have a very special guest with us today in Dr. Jonathan Menachem, who serves as the Director of Advanced Cardiac Therapies for Congenital Patients here at Vanderbilt University. Dr. Menachem, welcome.
Hi, thanks for having me.
So Dr. Menachem, I have to start off by asking you, how did you first get interested in adult congenital heart disease?
Yeah, so it's sort of a long story, but I'll try to keep it brief. I had actually no intention of going into medicine. So initially I did investment banking and then proceeded down a different path. And I'd gotten to spend some time in the cath lab as I was thinking about medicine and worked for a medical device company that did cath-based procedures. So I went into med school thinking that I was going to do cardiology. And somewhere along the way, I read this incredible book called A Walk on Water, which was about pediatric congenital surgery. And I don't know why I found it so incredibly fascinating. But so I got to med school and then decided that, okay, I was going to do something with congenital heart disease. And I wasn't sure if I was going to do pediatrics or adults or whatever. And sort of the right doors opened and I met the right people and got interested in adult congenital heart disease. So, and then that was my plan all along, was to sort of do a combined fellowship or training in both adult congenital heart disease and heart failure, because I had a very distinct interest in both of them. And so things worked out really nicely where I was able to do advanced fellowships in both congenital heart disease and heart failure at Penn.
That's quite interesting. So that brings me to my second question in that it's, from what I understand, it's very rare for people to be trained in both adult congenital as well as heart transplantation. So what would be your advice for fellows in training that may be interested in following your footsteps into how should they be shaping their training to kind of be able to do the kind of services you are able to provide to our patients?
Yeah, so it's challenging and one of the difficulties is after I did this, the ABIM has now said that the training would have to be longer. And so in order to do this would require you to do 3 years of general cardiology, 2 years of adult congenital heart disease, and then a year of heart failure and transplant. I was fortunate that at Penn, when I was there, I was able to do 2 years of general cardiology. I did 1 year of adult congenital heart disease, and then I did a heart failure transplant fellowship. So I think that part of what you have to figure out is what your true interest is. Do you want to do mainly adult congenital heart disease and see some patients with heart failure and transplant? Or do you want to do heart failure and transplant and see only the really sick adults with congenital heart disease? And for me, it worked out nicely that I really loved transplant. And I loved seeing the really sick congenital patients that were going to need advanced therapies like mechanical pumps or transplant. So I became more of a heart failure transplant doc who focuses on adults with congenital heart disease. So I think it's really important that people sort of know, sort of which way they're leaning, because I do think 6 years of training is too much. That being said, I think what's helpful in general cardiology training is that you're only required to do, I think, 2 weeks of adult congenital heart training and about a month of heart failure transplant. And I think that if you're thinking about doing a pathway down one of these lanes, I think you need to do more time in those during your general cardiology fellowship to get a better understanding of what it would entail and how much time it would take.
So as you have kind of embarked on your journey over the years, what would you say have been the most prominent changes that you have seen in the field of adult congenital patients that are transplanted with heart transplantation? Like, what have you seen in the field as it has evolved in the last decade or so?
I think the main thing is that people are becoming less afraid of congenital heart patients and recognizing that it's a growing niche and there's hundreds and thousands of these patients that are going to wind up on our doorsteps. So if you look at, for instance, more recent data, that there's about approximately 500 single ventricles that go down the Fontan route every year on the pediatric side. These patients are all going to wind up needing transplants. So I think we've become a little bit more willing to transplant these patients. And I think, but we're not there yet in terms of feeling completely comfortable. And I think some of that has to do that we don't always, they're high risk and we don't always know the data. But one of the things we're definitely getting better at, the idea of seeing these patients earlier. And I think there's a disconnect that exists in a lot of places between heart failure and ACHD. And this is why I like what I do, because I get to bring those two groups together in that, you know, a lot of the ACHD community feels that the heart failure transplant community won't transplant our patients. The flip side of that is that the heart failure transplant community says they only send us these really sick people that are blue. So there has to be an ability for both of these teams to work together. And the centers that have done the best job and have been the most successful in transplanting these patients are the ones where they've taken a collaborative, multidisciplinary approach to evaluating the patients and thinking about them, that let's get these patients before they're too sick to undergo transplant.
So from what I understand from what you just mentioned, it seems like, one, a lack of awareness about advanced therapies that are available for these patients, and that leading up to delayed referral for these patients for advanced therapies seems to be playing a prominent part in perhaps us depriving these patients of the advances in heart transplantation that is more broadly available to other patients. Do you foresee any other challenges moving forward in kind of expanding this resources to this particular patient population?
I mean, I think what we have to do is we have to form together as a community and say, how do we improve outcomes and how do we all work together? And I think another big thing that we have to wrap our heads around is that not every center and not every place should be doing VADs or transplants for these patients. So, and it's not because they don't have the right, they don't have the right interest, or that they're not smart enough or capable. But what we've shown in a paper, I think it was about a year and a half or 2 years ago in JHLT, was when we looked at patients that were with congenital heart disease that were transplanted, those who underwent transplant at medium or high volume centers, so greater than 14 transplants done per year, had a statistically significant improvement in outcome, so mortality. So what does that mean? Well, I don't think it necessarily means that your adult congenital heart providers don't know how to take care of these patients at centers that are doing less. And I don't think it means that the transplant centers that are doing lower numbers of transplants aren't capable. I think it's having all of the pieces in play beyond the pre-management and also the surgical management. It's all of the ability of ICUs and respiratory therapists and physical therapists to manage these post-transplant patients. And in the larger centers that are seeing more transplants, they're having better outcomes. I mean, that's not really surprising. This has been shown in every different aspect of cardiology, and not even in cardiology. It's been shown in appendicitis. So, you know, the more you do, the better you get at it. What was interesting about that data too was that it's not number of congenital patients that are transplanted, it's total number of transplants. So now I wouldn't argue that we should be sending congenital patients to centers that aren't familiar with congenital patients. I don't think that's the right approach. I think these patients need to be evaluated at high volume multidisciplinary centers and undergo transplant or mechanical support there.
So going back to your comment about early referral, I mean, given the complex anatomy and the various shunts and other physiologic changes that a lot of the congenital patients have, how reliable are the conventional ways in which we identify the readiness for a patient to be transplanted, such as Swan-Ganz catheters, our estimation of cardiac outputs, cardiopulmonary exercise testing? And so in your experience, are these still reliable? Are these still validated? Or should we be more focused on the clinical syndrome of the patient rather than some of these absolute values?
I think it's a mix of all of those things. So first of all, I think that as soon as you think about transplant in a congenital patient, they should be referred. Now, that doesn't mean that they need to be transplanted at that minute. But what that means is we're going to get another set of eyes on the patient. We're going to get a different view on the patient from a different team. And we're going to get them plugged into the general transplant process. I think everybody's got to work together on this. I think where the community at large has been incorrect is on ACHD providers saying, we're going to hold on to the patient until we decide they need transplant. We're going to do everything we can. And then when they need transplant, we'll send them. I think that's the wrong method. I think ACHD providers should absolutely do everything they can for the patients. I think they absolutely should do all the things they think need to be done. But these things can be done in parallel. And so while we're thinking about, maybe obstructive lesions or other surgeries, we can be going down the transplant pathway as well to see what other options can we offer the patients. And that's one of the things we've done at Vanderbilt, which has been really helpful, is that we've said, send the patients to me early, and I'm not going to take the patient. I don't own the patient after that, but we're going to help manage them together. And there have definitely been some patients that have been sent here that our ACHD team will review their stuff and say, you know what, they need a membrane resection or their baffle is occluded. We should go down that pathway first. And then there's other ones that are getting ready to be sent for a valve. And we'll see me and our transplant group in clinic, and we'll say, I think it might be time to move faster towards transplant. The next thing you're asking, which is a really good question, is what are the validated methods? And we don't know, is the truth. We're looking at a whole bunch of different options for the patients and thinking about them in different ways. And when I've looked through our data here, even all of our Fontans, single ventricles, have presented with all sorts of different problems. They don't follow the same path. I think that's why the more eyes you get on them, the better off they do. Because even if you're not a congenital, you don't understand all of the anatomy, you still understand heart failure. And we can pick off, different things to look at. We lean very heavily on cardiopulmonary exercise tests here. There's good data out of Boston that's shown that decline in peak VO2 can predict mortality. Now, it's not perfect data and it's small sets and whatever, but we do put the patients on treadmills very often. And what we find is that, if forget about the actual numbers, but if they were, like their peak VO2 and slope and that sort of thing, if they were able to walk 12 minutes on a treadmill, 6 months ago, and now they're doing 4 minutes, that's a dramatic change. And we're using those sort of things. And I think the key to this is that once we sort of feel like they're heading the wrong direction, being early to transplant is always a better option for these patients. The stories are immense about the number of people who've been like, we should have done this sooner. While I recognize that we don't want to transplant someone too soon, it's tough to know that it's too soon. And we do know that that getting patients into transplant when they're healthier and not as frail and able to walk more and have better muscle tone and normal renal function, those all portend a better outcome afterwards. So that was a very long answer to a very short question, but it's a very complicated process.
Well, I'll take the blame for that, for asking a very complex question in such a short sentence. So one of the things that we always face and hear about in heart transplantation is the availability of the organ. And over the years, we have tried to expand the pool of available organs for our transplant patients through accepting Hep C donors as well as DCD hearts. Have you seen an uptake in the utilization of these organs for the adult congenital patients, or are we still lagging in that?
We're lagging. is the long and short of it. I think there initially was a lot of uncertainty about whether or not these patients, it was safe to use Hep C organs. We've had really good outcomes and good data. Dr. Schlendorf from Vanderbilt has published the biggest study on this. So we've been pretty aggressive here about using Hep C organs. We've done actually 2 single ventricle Fontans with Hep C positive organs. One was a heart alone and one was a combined heart liver. That opened up a whole nother area of transplant for us. The other option is this newer area of using the transmedics, the transmedics box to reperfuse. Okay, we got to explain this differently. So let's edit this out. Let me try to answer that differently. So the other 2 options are, DCD hearts and extended donor criteria using the transmedics box. There are some centers that have done this, and we've considered doing it for our transplants and for our congenital patients that are listed. I think that we need to be thinking about opening up as many options for these patients as possible, specifically because of what we know about how they do on the wait list. So one of the things we know is that patients, so we know a few things, right? They get listed later because because of this whole idea of late referral. Then because they often don't meet the normal criteria, they may not be at a high enough status, which is a whole different project and problem we can talk about. So knowing that, then we know that when they're listed, and this was shown in data last year in JACC, where they looked at waitlist mortality. So in the old system, adults with congenital heart disease listed 1A had significantly worse outcomes than non-congenital patients that were listed 1A. And that's probably because of their severity of illness by the time they met that 1A threshold. Mm-hmm. So we need to do whatever we can to get these patients organs. So I absolutely think we should be opening up as many doors and possibilities as we can.
And what would you say you foresee the future of this field of adult congenital heart disease and heart transplantation? What are the things that excite you the most that are in the pipeline, or perhaps you hope to bring in the pipeline over the next 5 to 10 years?
One is we got to get patients referred sooner. I think we have to have better collaboration within ACHD and heart failure and transplant, both within institutions and then nationally. And I think I'm excited about the fact that we're starting to do, and I think a lot of centers be more aggressive with what we know about heart failure and apply it to congenital heart patients. So, if we're expecting that we're going to have a 20,000 person study on Entresto in congenital patients, that's never going to happen. Okay. So, but we should be able to learn from the Entresto data and say, you know what, if we have an L transposition patient, so a 2 ventricle patient with a systemic right ventricle, let's think about treating that patient just like a non-congenital patient, and let's start them on Entrestos and beta blockers, and maybe they need cardiomems. Let's use all of the things we can use and see what happens. And I think we're just going to have to be okay with the fact that there is no data. And, what's fascinating and fun about congenital heart disease too is that providers are accustomed to working in this world of no data. And it's incredible because the patients are also used to that. So when you talk to these young adults and you talk to their parents and you're like, look, let me explain to you, we're going down a route, right? We're talking about transplant. There's a lot of unknowns. They're like, oh yeah, we're used to that. When he was born, they had never done this before, and look at this now. So, I mean, this whole field was built by surgeons and pediatric cardiologists who were taking chances, calculated risks, right? But saying, we have to move, for instance, from the atrial switch, the mustard and the sending, to an arterial switch. Imagine what you're like as a parent that like, hey, we've never really done this before, but we think this is better. And you know what? The parents got behind it, the providers got behind it, and now we've made a big impact on the field. So I think that's part of it. Transplant and bad is the next thing, is that if you take this the single ventricles out of it altogether, a lot of what we're seeing are tetralogy of Fallot patients and systemic right ventricle patients. But these are two ventricle patients. We need to be aggressive about how we're treating them with meds, and then should we be offering them sooner mechanical support or transplant? As it pertains to the Fontans, there's a lot we don't know, but I think everybody's sort of working together. The big unknown continues to be, what should we do about the liver? There's some centers that say that every patient with any sort of bridging fibrosis or cirrhosis, absolutely, those Fontans get combined heart liver. There are some centers that say absolutely they need heart alone. And then UCLA published a nice paper, and what we believe in at Vanderbilt is maybe they need heart liver, maybe they just need heart. So we're trying to figure out how to best evaluate all of these patients. But again, then it's always best if multiple people are seeing them and we're seeing them before they're too sick.
Well, this has been a fantastic chat with you, Dr. Menachem, and thank you so much for shedding light on what's been the past, what the present looks like, and from borrowing your terms, it looks very bright that the future for these patients that start off their journey with a little bit of a disadvantage, the future looks pretty promising for them. And thank you to physicians like yourself that do go through the rigorous training to have the combined training and help set up programs that allow for these patients to have a second chance.
Yeah, well, I'm happy to do this. And honestly, if anyone wants to reach out or has any questions, I'm happy to talk about this, because I think what we need is more fellows and residents that are interested in these fields and how we get them down the right path. And it's not the norm, but this is a very quickly growing area of cardiovascular medicine. So we're going to need more people to take care of these patients.